Hello, everyone, and welcome to the Brian Grant Foundation's Wellness Webcast. I'm Amy LaValle, your Parkinson's Community Liaison and host of today's program. We have a wonderful presentation today: depression, anxiety, and apathy. These are three distinct mood states that I know many of us have experienced. I'd like to invite you to ask your questions during the presentation in the chat box below, and we'll do our best to get to them. Now, I'd like to introduce today's presenter, Dr. Michelle LaValle Dagostine. She's a movement disorder specialist with the Hartford Healthcare Medical Group and is part of the Chase Family Movement Disorder Center. Dr. Dagostine was the Associate Director of Clinical Research at the Institute for Neurodegenerative Disorders for several years prior to joining the Hartford Healthcare in her current role. Dr. LaValle, Dr. LaValle Dagostine. Thank you for joining us today. It's so wonderful to have you back. You are pro at this, and you can just give the best information. So I'm going to just hand this over to you.
Okay, I'm going to go ahead and share my screen. And in case anyone's wondering, yes, we are related. That is not an accident. All right, I'm going to hide these floating controls and we're going to get going in just a second here. Okay. All right. So, all right, can you guys see my screen? Aim, can you see it?
Yes, you're good.
Okay, awesome. So today I'm going to talk about anxiety, depression, and apathy. I have no disclosures regarding the material. Quick disclaimer, this is for informational purposes only. And what do I want to do today? So I want to just help you identify the symptoms because I think it's a little confusing and they're quite different in Parkinson's versus people without. I want to help you tell the difference between depression and apathy because I don't think we do a great job in the community explaining what apathy is and how to tell them apart. And it's important. I'll tell you why. And then I want to give you some approaches to treatment and management. And then at the end, when we're done, I have a whole section in a toolbox that I put together. So it'll be available for you afterwards on the website. And they're just practical things that you can do. So yes, you're going to get this information, but what do you do with it? There's a toolbox at the end that I'm not going to go through today unless you guys want me to and there's time, but it's going to be available for you on the website. I thought, who better to start with than Brian himself? Brian has been pretty transparent about depression after his diagnosis. What's interesting is that, when you close your eyes and sort of think about depression or anxiety before you've got Parkinson's, you may have an idea of what that looks like. In a really nice interview that Brian did with Brain and Life in 2022, he talks about this idea that, I think a lot of the general public have, that if you're depressed, maybe you're weak-minded, maybe you're not trying hard enough. And then he says, as soon as he got diagnosed, those thoughts, they changed really quickly. He called it no joke. He said something that I reiterate to my patients all the time. It's not something you have control over. And if you take nothing else from this webinar, I want you to take that. A lot of times people will say, oh, I'll just try harder. I'll get more exercise. I'll get more sunshine. If I just worked harder, this wouldn't be going on. I can gut it out. And that's not the case. We'll talk about why later. The other thing he talks about is when it hits, it hits. Anyone on this call right now who has suffered from depression or anxiety with Parkinson's absolutely knows what he's talking about. It can hit you like a Mack truck and it comes out of nowhere and it just stops you. He calls it paralyzing. So he did his training camp in 2007. And for the first time, his body wasn't responding the way that it used to. And it clicked something in him. Something hit him. He knew something was wrong. He just was so frustrated. He got home. He didn't want to go anywhere. He didn't want to do anything. This highly motivated guy didn't want to do anything. And I hear this from people all the time where they say, I just don't feel well in my own skin. I don't feel right. I can't put my finger on it. I don't know what it is. I don't feel right. Right. And he talks about it here in the interview where he says, all these people are saying, I think you're depressed. But the way that you feel when you have Parkinson's and you're depressed, is not what you envision in your mind. You have a picture of someone maybe in bed and feeling down, and everyone's going to tell you, well, you just got diagnosed. I think you're depressed. But the depression we're talking about today is not being upset that you were diagnosed. In over 2 decades, I've never had someone happy to be diagnosed, but that's not what we're talking about here. So, what he talks about in this interview, and I think is important, is that you've got these people saying, I want to help you. I think you've got depression. I think you're depressed. But that word doesn't resonate. It doesn't click in your brain because that's not what you feel like you have. And so that's why I want to kind of go through with you today. Well, what is depression, right? How does your brain control your mood? Because this isn't something where if you just tough it out, like I said, you're going to work harder and things are going to change. We've got structures in the brain that are important. But today, what we're going to focus on are those brain chemicals, those neurotransmitters. These are the ingredients to make you feel calm when you should feel calm, to feel happy, to feel motivated, to feel focused. They're important. And when you don't have enough of them, just like you can't bake a cake without ingredients, you cannot force yourself to feel certain ways. Okay. We've got serotonin, nickname is the happiness chemical. Many of you have heard of it. Dopamine, you don't stop hearing about it from the minute that you are diagnosed with Parkinson's. Norepinephrine, it's also known as noradrenaline. Adrenaline, gets you going. And then GABA, which is calming. So in Parkinson's, again, we hear about dopamine all the time, nonstop. But what you don't often hear about is that your levels of norepinephrine and serotonin go down also. So your body wants everything in balance, right? Everything in homeostasis. And what ends up happening is that this is what's, I see a question already. This is what's involved in depression and Parkinson's. So acetylcholine is involved, but not in this particular case. So when you're looking at Parkinson's, it affects a lot of the different chemicals, but in particular, these three for depression. And when we look at depression and how it's diagnosed, you have to feel sad or have a depressed mood. That is key. This is going to be important later. So that's the first part. You have to have at least 5 of the next bullet points. And what I want to just bring your attention to here is how many of you who have Parkinson's can identify with some of the things I'm going to list. Not because you're depressed, but because because there's overlap. So loss of interest in activities, changes in appetite where there's weight loss or weight gain, trouble sleeping or sleeping too much, loss of energy or fatigue, sound familiar? Slowed movements or speech, feeling worthless or guilty, difficulty thinking or concentrating, or thoughts of death or suicide. So in Parkinson's, the numbers are about 30 to 40% of people with Parkinson's will be diagnosed with depression. And I think a lot of this has to do with the fact that it goes under recognized because of things we're going to talk about in a minute, but also because there's still a stigma about depression and anxiety and mood disorders, right? Nobody shames a type 1 diabetic for needing insulin, but somehow if you're depressed or anxious, you should just make your brain, which is also an organ, make more of these chemicals. So when you put those together like that, you can see how that doesn't make any sense. Of the 30 to 40% of people who actually have been diagnosed, only 20% are going to receive treatment, which is really sad. Because when we look at, quality of life in Parkinson's, mood disorders have arguably an even more significant impact than the motor symptoms, depending on what studies you look at. So some of the barriers then to diagnosing it is that if you've got Parkinson's, sometimes you don't recognize.
Michelle, your microphone is getting a little blocked.
Oh, can you hear me?
Now you sound
How's that?
Yeah, thank you.
Is that better? People with Parkinson's often don't recognize that they have, a mood problem, as I mentioned earlier when I was talking about Brian, because of some of the physical changes in Parkinson's that are similar to things that are seen in depression. People outside of you may not recognize changes. There's a lot of overlapping features: fatigue, changes in energy, changes in appetite, changes in sleep, gastrointestinal problems. And in depression, without Parkinson's, you can get slowed movements. So when you see here psychomotor retardation, What that means is slow movements. That's the medical term for it. But you can have changes in your facial expression, kind of like hypomimia. So there's so much overlap. It really becomes very challenging to sort of pull them apart. And we hear that a lot in the office. Well, how do I know what symptom is from Parkinson's? How do I know what symptom is something else? So how do you tell the difference when there's so many similarities? For the depression, for a diagnosis, you have to have, again, the sadness or poor mood. And then five or more of those bullet points at the same time. Has to be present for more than 2 weeks. And it's got to be present for the majority of the day. So it's not something that kind of comes and goes and comes and goes. And the reason that's important is that with Parkinson's disease, as many of you may or may not have seen, you can see significant mood changes related to your medication and when it wears off. I know you guys have seen this a million times, but what I want to point out to you is that when you're wearing off, when those blood levels of dopamine are low, so this is just showing you, for if you haven't seen it, this is just blood levels of levodopa. Levodopa, again, is just the ingredients to make dopamine. It's just amino acids, nothing that's not supposed to be in your body. But over time, it's harder to stay in an area where you have the right amount. And that's because you lose the cells to make dopamine. So think about having 100 ovens. You can bring in a ton of groceries in the beginning and make a lot of different food. If you're down to 50 ovens, you can't make as much, right? And so you have a harder time as the disease progresses. But when you're wearing off, so on that downslope, in that dark blue area at the bottom, people are going to have a lot of symptoms that are not just tremor or stiffness or slowness. And so, my patients laugh at me a little bit sometimes, but when we're having symptoms, I take out my notepad and we'll go through their day, hour by hour, looking at medication, looking at the time of symptoms to figure out, is what we're experiencing wearing off of your medication? Because you can see depression, anxiety, pain, shortness of breath, sweating. I mean, I can go on and on. And so we really want to track them and see, what's the trend. Is it a certain time of day? Is it when you're due for your next dose? Is it when your dose has peaked because now you have too much? So you really have to kind of dig in. You don't need weeks of information. You need a couple of days of information, because it's asking a lot to have people track this. I also ask people, has your manufacturer changed, right? So were your pills, white and now they're tan, or were they blue and now they're yellow? Manufacturers can change, and they use a different binding agent. And so sometimes for people, you're not absorbing as much. And so maybe you were doing just fine. None of your doses were changed, but now your manufacturer changed and you're having a lot of problems. It's something you really want to look at. Dietary changes. I have a lot of people struggling to maintain their weight. A lot of times families, or you'll add on a protein drink. You can get protein drinks all different kinds of fun ways now. It doesn't have to be, boring, old, and sure anymore. But what I'll find sometimes is that people are really down in the afternoon. Well, they've added a 3 o'clock protein drink, perhaps with one of their doses, and they're not absorbing as much. And so this is a wearing off phenomenon. We do blood work because Parkinson's does get blamed for darn near close to everything. It touches every organ system. You don't want to miss something that's very easy to fix. Low vitamin B levels can be a problem, even if they fall into the quote normal range. In the world of neurology, low normal B vitamin levels are not normal, right? So you never want to assume that it's Parkinson's without giving somebody the opportunity to have some blood work, kind of look at what else is going on, because you deserve to have someone look past the Parkinson's. I have this happen all the time, where someone will say, well, it's just the Parkinson's. And you'll say, well, could you just treat them like you would treat anyone else, and like actually take a look? And, sometimes it is PD, but there are times when it's not. We look at sleep. Sleep is a problem almost universally for people with Parkinson's. And I gave a lecture actually on that before. But if you're not sleeping and you're not consolidating memories and you're not getting that good restorative sleep, you're going to be depressed, or you're going to feel depressed. You're going to feel down and slow. Your movements are going to be slow. Your stress hormones are going to be elevated, that cortisol. and that's going to, increase anxiety. So I know you're tired of hearing about it, but also hydration. I know we hammer you with the hydration, please drink, please drink. Oftentimes ignoring that it's hard for you to get to the bathroom. You have urge incontinence. You're not thirsty. You have stomachs that are not emptying as quickly as they should be, so you feel really bloated and full sometimes. But anyone who's seen somebody who's dehydrated get a bunch of fluids in them and then perk back up, you know that if you're dehydrated, your brain just can't function the way that it's meant to. So we always look at the medication ways to fix things first. So when someone comes in and they're having depression, I'm always looking at medication timing, and looking to either adjust the timing or how I'm delivering it. So many different topics, that's a whole discussion in of itself. Doing the best we can to optimize lifestyle and realizing we're not looking for perfection, right? No one has to be perfect to have some kind of an improvement. And I think a lot of times what people try and do, and I've got a little slide on this later, is that you try and change too much at once. And when you don't get things perfect, people kind of give up. You bite off more than you chew. So if you're drinking 8 ounces of water a day, you're not going to go to 64, right? That's not a realistic expectation. You're going to set yourself up for failure. So we try and realistically make some changes here. Counseling and psychotherapy, I think, is really frustrating for people, because it was bad before the pandemic to find someone to take you on. Since the pandemic, it's been even worse. Trying to find someone in network, someone who takes insurance, someone who doesn't meet you for the first time and say, I have no idea what to do with somebody with Parkinson's, and so it's frustrating. What I tell people is that, most of us, now some of you did, but most of us did not marry the first person we dated. There's a very good chance that the first counselor that you meet is going to really disappoint you. And if that happens, what I hate to have people do is kind of give up because they're frustrated. It took so long to get in. It was so hard to find this person. They have no idea what I'm dealing with. And you think, forget it. It's not worth my time. But I want you to hear this. You deserve better. Just because that person isn't educated in what you have going on does not mean that you don't deserve to have that therapy. And just because you're a smart person, just because you know what's going on in your head, doesn't mean that therapy can't be helpful if you find the right kind and the right sort of balance. So I know it's hard to find a good fit, but I want to encourage you that if it's not a good fit, fire them. I mean, give them a chance, but then you fire them. They're just, they're working for you. And then you keep trying to find someone who gets it. And if they don't waste your time. And then the support groups in the national organizations are fabulous. Brian Grant has these webinars, and every Tuesday they've got the mindfulness classes. So, I think going to the groups helps you not feel so isolated, but also you don't have to reinvent the wheel. Parkinson's is the second most common neurodegenerative condition in the world. You're not alone, but sometimes you feel like you are. People have gone through this, and there are people who really get it. And when they get it, you can say things in a way that maybe a doctor they're not going to click. They're not going to understand it, but you can say it to another person who's going through what you're going through, and they can say, oh, I feel exactly like that. Let me tell you what I tried. And so I think it's an invaluable resource. When we look at the drugs, I'm not going to spend a lot of time on this at all. But what I want you just to take away from this is, if you look at the umbrella of what these do, is they're keeping your body from breaking down what's supposed to be there, right? You're not putting stuff in that's not supposed to be. You're supposed to have serotonin. You're supposed to have norepinephrine. You're supposed to have dopamine, and you're supposed to have good levels. And when you don't feel well. And so the point of these is that, you want to help keep the levels where the brain actually wants them. And that can be tricky. I would be remiss, if I didn't put in a slide about suicide. It's not a topic people like to talk about, but, 30% of people with Parkinson's have thought about it at one point or another. And it's important to be open about it because, oftentimes it's something that people don't hear about until unfortunately it's too late. One of the signs for people who love people with Parkinson's, right? You're looking for if people are talking about suicide, harming themselves, killing themselves, do they have a plan? If you see a dramatic mood swing or personality change, if you hear people talk about feeling helpless, hopeless, trapped, like all hope is gone. I've all the resources are not working, nothing's working. I've got nothing left, to try. When you hear people who are talking about like self-loathing or self-hatred, I'm such a burden. I never wanted to be like this. I'm the one who's supposed to be taking care of them. They're not supposed to be taking care of me. These are things you want to pay attention to. And not everyone who talks like this is suicidal, but you don't want to miss it. People say goodbye, or there's an unexpected call or visit where they're kind of acting a little strange. People with Parkinson's tend to socially isolate for a whole nother, a variety of other topics. It's, that's a whole nother talk in and of itself. But if you're really seeing someone withdraw, they never want to go out and do anything. You want to keep checking on them, as annoying as you might be to them. It's worth it. And then the biggest one, honestly, is if someone's been really depressed, but then all of a sudden they're happy and they're calm. And that's concerning because you're worried that maybe they've made a decision to do something. There are hotlines. I have a slide at the end with some resources because I just think that that's really important and it doesn't get talked about enough. I'm going to move on and switch over to apathy. I don't think we talk about this hardly at all. So apathy and depression are very different. And I don't think people know much about what apathy is. So depression, again, you're sad, you're down. Apathy is a motivational problem. And so with apathy, you are totally indifferent. You don't care. It's a big problem in Parkinson's because and I laughed at these numbers, 12 to 70%. I'm going to tell you, the 12, I don't know I don't remember which study that came from, but that's incredibly low. But there's a fair amount of people who will be diagnosed with apathy. You can see it as early. Oh, is my audio still breaking up? Oh, hi, Roger. Let me see.
Seems to be when you lean further back. So if you're a little closer, it's just fine.
Oh, okay. So okay, can you hear me now?
No.
Okay.
Nope.
How about now?
That's better.
Okay. So, you can see apathy as early as, 2 to 9 years before the diagnosis. People with apathy, keep in mind, they're not sad and they're not depressed. You see it more in people that have memory changes, more advanced disease, and older age. So if we look at the brain chemicals associated with apathy, there's a lot. Dopamine, we all hear about. It's a major chemical. It is the major chemical in the motivation pathway. But so is serotonin, so is noradrenaline, norepinephrine, acetylcholine, as someone was mentioning earlier. You've got glutamate involved and GABA. So you've got all of these chemicals. And in Parkinson's, you don't have enough of them. So when we look at differentiating, right, apathy is a motivational disorder, depression is a mood disorder. So with apathy, it's not that you don't want to do something, you just don't care, right? In depression, you don't want to do it, so in depression, I don't want to go take a shower. In depression, I don't want to go exercise. With apathy, your brain never offers it to you. Your brain never says to you, it's time to go shower. You should clean yourself. It just doesn't offer it to you at all. You're very flat. Those times where, the care partner might leave the house and you come back and the person with Parkinson's still sitting in the same place and they haven't moved and they haven't eaten and they haven't done anything. And it's a real problem because remember, it's not your fault. It's a chemical issue. That's what it is. You can't drive a car without gas. You can't have proper motivation when you're missing darn near close to every chemical you need. The reason why it's important to recognize it is because when you've got apathy and it's unrecognized, people are not doing their activities of daily living. They're just not, because their brains are never going to say to them, get up and go take your pills. Oh, it's time to go stretch. Log on to that webinar. It's not going to be offered. They have worse outcomes. because they're not taking pills on time. They're not doing the things that they know that they need to do. And it's not that they don't want to. And if you, as the care partner or loved one, will say, hey, here's your meal, here's your pills, I'm taking you to the store, they'll go, but they're not going to offer to do it on their own. One of the number one areas that I see problems arise from this in my world is that care partners get very frustrated when they don't know what's going on. It feels like people are only doing things when they want to and when they feel like it, and that's not the case. If you're dealing with apathy, it's not that you want to sit down and not do anything all day. It's that your brain is absolutely not telling you that there's any other option. And so as a care partner, you might be frustrated, rightfully so. You know, someone's not taking their pills, so they don't function as well. When they don't function as well, that's harder on you. So it's important to understand what's going on. And also, if you mistake apathy for depression, what's going to happen is that you might use a medication like an SSRI, like escitalopram or citalopram. That makes apathy worse. So if you get it wrong and someone starts a med for depression, you're actually going to make the problem even worse than it already is. It's a big issue. So it has unique challenges. The brain, as I said, it's not going to initiate activity. You have to schedule things. If you do not put something on a schedule when you are dealing with apathy, I'm going to tell you right now, it's not going to get done. You have to prompt. You have to say, okay, it's time to go do this. Look at the schedule. It's time to go do that. Because if you just wait for someone to do it, it's not going to happen. It's not going to happen, and it's not the person's fault. I mentioned it's a really major source of conflict. You know, I'll have spouses say, you know, God, he won't even take out the trash. I've been out doing all these things and I'm trying so hard and they're not helping at all. They may not tell them to do it. In over 20 years, I have had one person ever say to me that they just didn't want to help their spouse. You know, one person ever. So, always give people the benefit of the doubt. So, for strategies to support someone you love who may be dealing with apathy, is you really got to have a routine. Now, the caveat here is that if you're retired and you've been working your whole life, I'm not suggesting that your routine includes an alarm to wake you up and being scheduled every hour. Like my mom's a retired teacher. Man, she'd kill me if I ever did this to her. So I want to just make sure you understand when I'm talking about a structure, it doesn't have to be strict, but getting into those routines is very helpful. You have to set achievable goals, right? If you're going to work for the day, you can't just have a honey-do list and think any of that's going to get done. I have to be honest with you, you're setting yourself up for failure. It's not going to happen. And even if you're the person dealing with apathy, you have to set very specific goals. I'm going to talk about that also in a minute. But what you also want to remember to set yourself up for success is you can't pick something that's so big that you're never going to accomplish it. Because not only will you not do it, you will get this sort of negative reinforcement that you can't, and that does not motivate people. So if your brain doesn't say to you, this is stupid, this is too small, your goal is too big. There are sometimes with people that I take care of where, we're having a tough time getting them exercising, and I will have them put on their gym clothes or whatever their workout clothes are every day at the same time for a week, not even work out. And they'll go, come on. It's so dumb, but it's so dumb you can't fail, right? You have to pick something that's so small that it just begins that routine, right? You're stacking those habits. You want to engage in something that stimulates your brain. It's got to be something you like. Don't get people Sudoku who hate Sudoku. I see people kind of, try all the time to provide people with ways to stimulate their brain, but in ways that people never did before, don't like, and they're never going to do. So you have to kind of be a little bit mindful of that. And then going out and doing things that you used to love. So again, you're not going to get as much joy out of them as you used to, but if you're someone who used to volunteer at a soup kitchen, your brain's not going to say, hey, let's go on Thursday and help out. But if someone brings you, I guarantee you will enjoy yourself while you're there. You have to, again, pick activities people like. Don't force them to do something they don't like to do. You're not going to do anyone any favors. The the phrase SMART is what we usually refer to when we're talking about goals they're specific, right? They're measurable. So if you want to work out, you'd say, I am going to go on my recumbent bike for 20 minutes Monday, Tuesday, and Thursday at 10 a.m. Like that is a SMART goal, right? It's specific. You can measure it because at the end of the week, either you did it or you didn't. 20 minutes for some people is not attainable. So if it's not, maybe you say 5, maybe you say 3. It's got to be realistic and it's got to be timely, right? You're not looking at a 3-month, a 6-month, a year goal. We're talking immediate. We're talking 1 week. And I like this illustration, and I've used this before. I think just human beings, we want to get places faster. We want to make these big steps. We want to be done. You want to get back to the way you were at the gym however many years ago. You want to be talking as loudly as you were 5 years ago. You want to do these things and you want to get there as fast as you can. But like I was mentioning earlier, you set those rungs too far apart, you're never going to get there. So, as frustrating as it may seem to keep them smaller, it really is worth doing it because it gives you a much greater chance at succeeding. And there's some very, very good scientific data behind all of that. Just keeping an eye on time. For anxiety. So, what's interesting with anxiety is you're supposed to have some. It's a natural emotion, it's a natural response. You're supposed to have it. And I think a lot of times when you have an anxiety disorder, right, which is where you have intense feelings that are excessive, persistent worry, right, about things that probably shouldn't make you anxious, people will say, oh, come on, it's not that bad. Just come take some deep breaths because they're comparing their anxiety to yours because they do have some. They're supposed to. When a tiger chases you, you are supposed to run. What they don't understand is that yours is different, right? And so, anxiety that's supposed to be there, it helps focus and motivate you, helps you problem solve, it keeps you safe. It's that fight or flight. It becomes a problem in Parkinson's because you don't have enough serotonin, gabapentin, dopamine, norepinephrine. I mean, the changes, you're way out of balance. So I know this is redundant, but it's important because that when Brian Grant says it's not in your control, it's not in your control. 20 to 40% of people with Parkinson's will be diagnosed with anxiety, but I think that's underreported because people are embarrassed. What's interesting is that you have an increased vulnerability to anxiety when you have Parkinson's because of the chemical changes. The reason I have a picture of a threshold here is because in Parkinson's, anxiety attacks or severe anxiety can be provoked by things that really shouldn't be making you anxious. So you show a threshold to someone without Parkinson's and they'll go, why are you showing me this? Are you trying to have me look at your carpet? You show this picture to somebody who has freezing of gait at thresholds, they're going to sometimes panic, right? Those of you who have experienced this, I know your heart rate went up just a little bit, right? Because the first place your brain goes is, I'm going to freeze. Oh, what if I fall? There are people behind me. I'm slowing everyone down. Everyone's looking at me. I'm so frustrated, right? And anyone else looking at a threshold isn't going to think that. But for you, that triggers the exact same response as being chased by a tiger, right? Your body doesn't know the difference. We only have so many chemicals. They're exactly the same. So your body doesn't know the difference if you've got freezing of gait between seeing that threshold and being scared you're going to freeze and a tiger chasing you. It is just as real to your body. And so when we're looking at anxiety, the symptoms that you're seeing is that you've got this worry that you just can't control, right? You have a doctor's appointment on Thursday, it's Monday, and all you can think of is, oh my gosh, when do I take my Miralax? Am I going to have a bowel movement on my way to the doctor's? Is there going to be a bathroom that's close by? Darn, is it going to be a place where there's an elevator that it's too crowded? All kinds of things. And while a little bit of anxiety is normal to help you plan, perseverating about it, so running that loop in your brain until 3 o'clock in the morning for a week before, that's not helpful. People will they describe it a million different ways, but will have a sense of dread, difficulty concentrating. You can feel restless. People will just say, God, I want to crawl out of my skin. I don't know what's wrong with me, but it's driving me nuts. Um, that's anxiety and Parkinson's, right? And it's a chemical problem. And it's so important to tell us about it. You can be irritable. You can have mood changes. You know, our bodies were never meant to be under chronic stress. From a developmental standpoint, you were supposed to either get the tiger would eat you and the stress cycle was closed, or you got away from it and the cycle was closed. But when you never close it, right? Because things like thresholds are making you put up cortisol and adrenaline, it eats away at you. So who wouldn't be irritated, right? And who's not going to have a mood change? But it's important to know that. You can have the increased heart rate and palpitations, the rapid breathing, the sweating, shaking. They have a lot of GI symptoms that people don't talk about when you're in that fight or flight, because fight or flight is the opposite of rest and digest. So if you're under chronic stress, you're adding to your GI issues, right? We already know the stomach doesn't empty as fast as it's supposed to when you've got Parkinson's. We know the intestines don't move as quickly. But if you're under chronic stress because of the Parkinson's and the chemical imbalance, it's going to make digestion much worse for you because you're not in a state where your body can do it. And so these are just things to consider. The other things I don't think we do a good job talking about is that when people have anxiety and Parkinson's, a lot of pain, there's a lot of sensory symptoms, pain, numbness and tingling, changes in vision, changes in voice quality. I mentioned kind of the abdominal distension, but you can also have this bladder discomfort where you feel like you've got to go, which makes you anxious. And then you try and go, and there's not really anything in there, which makes you kind of more uncomfortable. And you get into a really nasty cycle. And you can see that with the medication wearing off. About 30% of people will have anxiety and depression, which makes sense, right? Because there's so much overlap with those chemicals. And again, if you really look at the data and you talk to people and you listen, the mood disorders have such a dramatic impact on quality of life. I just think we need to do a better job about talking to people and normalizing it. Not unlike depression, anxiety with Parkinson's, it 100% can be your medication wearing off. 100%. It comes in these waves that hit you out of nowhere and you were doing okay. And then all of a sudden you're completely non-functional. It's not your fault. It's a chemical issue, right? But it's important to know, and it's important for care partners to know, because it's not that someone's faking it or doesn't want to do something. It's that their body has responded to something that really probably shouldn't make you anxious, but it has shut them down like a deer in headlights. The interesting thing too is you can have psychosis. If the anxiety is bad enough, you can actually see things that aren't there. And it's important because you don't want to treat that with antipsychotics, which can block dopamine receptors. You want to treat the anxiety. So it's important, like I said, to really normalize it and to talk about it. These slides are exactly the same as the depression ones. You're tracking symptoms, you're checking your manufacturer, you're looking at the diet, look for triggers. Now, there are certain things that are definitely going to trigger you with anxiety, whether it's a threshold, doctor's appointments, long car trips, sometimes going to a restaurant where you think, geez, I know if I sit more than a certain amount of time, I might not be able to get back up. And I don't want people looking at me. And I don't want to kind of stumble and have them think I had one too many drinks. So there are triggers you can kind of look at and sort of try and plan for ahead of time. You can't avoid everything, but it's something to be mindful of because it really, I think, is important. The blood work, sleep, changes in routine, and changes in environment are really big for anxiety with Parkinson's. I had a patient who moved into an adult living sort of situation, and her next door neighbor was knocking on the wall and irritating her dog every time she'd leave. And so this change in environment, now she doesn't want to leave the dog, she doesn't want to go work out, she doesn't want to go do things because she's afraid of what's going on. So changes in routine and changes in environment shouldn't be discounted. You've joined a new gym, you're going to a new class, You know how people are territorial with their spots in those classes. So maybe you're anxious that you're going to be in someone's spot. What if they get mad at you? And now you've been shunned by the group. Valid concerns. Again, we're looking at optimizing your medications, lifestyle optimization, same kind of stuff. And I want to make sure that I leave time at the end. So that's why I'm kind of going through these a little fast. Same treatments, right? Some work a little bit better for anxiety, some work a little bit better for depression. We don't throw medications typically at apathy. It's more the strategies, the daily strategies. I will say that if you're someone who has tried several different medications for mood and you've not had good results, there's actually a test that can be done where they swab the inside of your cheek and they send it out. And what they do is they look and see how your body breaks down these certain kinds of drugs, these mood drugs. And it's really helpful. Your clinician, it's like prescribing for dummies. It's green, yellow, and red. And the red ones, don't even bother. Your patient can't metabolize it. It's not going to work. It's not going to help them. Don't even try. And it's very helpful. I have found that you don't waste 6 months or 9 months or a year throwing medications that should work at people and they don't, and someone's miserable for a year longer than they need to be. And when you want to create a supportive environment, you want a calm environment. I have a slide of this in the toolbox, so I'm not going to spend really much time on this. With the reassurance and support, I think the big part here is that if you don't have an anxiety disorder, it's really hard to understand Parkinson's anxiety. And if you can take a step back and always assume that the person you're dealing with at any given time is doing the best they can, you will be well served. You have to know that people can be fine in the morning. A wave can hit them and then they're not, and it's not a choice. And I know it looks strange because it's unpredictable. It drives my engineers nuts, but it's true. And I think that's really hard for people to see. So really kind of listening and willing suspension of disbelief, even if it doesn't seem to make sense, just believe them and try and work on something together as a team. Like I said, it doesn't have to make sense because anxiety doesn't follow logic. Break your tasks into smaller steps. When someone has anxiety, you can't give them, a 10-step process and say, hey, go take care of this on your own. They're going to freeze. They're going to absolutely freeze. Encourage relaxation techniques. I know everyone's tired of hearing about it, but the reason why those techniques work, and it's all in the toolbox at the end, is that it tells your body it's safe. And there's so many ways to do it. And so if you don't like one, it's like ice cream. You don't like mint chocolate chip, try strawberry. My mind's too busy for, silent meditation. So I have to do guided, but you got to try different things. What it does is it takes your brain, the very primitive part, and it tells it there's no tiger. You are safe. And when that happens, it stops the cycle and it stops the cortisol, stops the adrenaline. It brings you back into rest and digest. And I have seen people go from very severe, dystonic tremors to not shaking at all when their body finally felt safe. So even if it's not something you think you might enjoy, I would ask that you please try it. And then just a couple last slides here before we have time for questions. When do you ask for help? Because nobody wants to ask for help with this. And I think for a variety of reasons, it's embarrassing sometimes for people. Sometimes when you've asked for help in the past, people have not helped you. Or when you ask certain people for help, maybe they don't understand Parkinson's and their way of helping you isn't helpful. So if the symptoms are really interfering with your activities, it's okay to think, I want to change the timing of my Miralax so that I don't have a bowel movement when I'm out. That's smart. But if you won't leave your house to do anything because you're afraid of that, we can help you with that, right? That's not help. That's not what anxiety is supposed to do. If it's weeks and months of the same really debilitating anxiety or depression, if you're doing all the things, you're doing all the self-care, but no matter what you do, it's just not helping you. If you're just feeling so overwhelmed, you don't know where to start, right? If you're someone who used to drink wine or a beer and now you're drinking a box of wine, that's not a good sign. You're self-medicating. You don't have to do that, right? We can help you with things that are a lot healthier for you. And if you ever have thoughts of self-harm or suicide, please let somebody know. Your neurologist can help, psychiatrist, psychologist, therapist, so on and so forth. And as I said earlier, most people aren't going to like the first one that you try. Don't let that person's inexperience take away your opportunity because you deserve better. Um, this is just going to be here for later on. This is the help lines that will be available later. So I hope I've been helpful. I just want to show you real quick this toolbox. I'm not going to go through it, but I have slides on different tools, talking about that stress cycle that I mentioned. Everyone's always telling you to exercise, and it's great, but it's not practical for everyone. So I wanted to give you some techniques where if exercise is not the solution for you, you're not out of luck. There's a lot of ways to tell your body that it's safe. A couple breathing techniques here, right? A little disclaimer for the box breathing and the 4-7-8, because with people with high blood pressure, if you hold your breath, your pressures can go up. That box breathing is actually really good for when you're trying to focus, like during the daytime, and the 4-7-8 is really good when you're trying to go to sleep. Different grounding techniques. And again, some are going to seem really hokey, but you're not going to hurt to try it. You're trying to calm that central nervous system. I listed all the different kinds of meditation because, as I mentioned, it's not a one size fits all. It's a lot of different flavors. Journaling, little bit in there, and then so that's going to be available for you afterwards because we talk all about this, but we don't really give you tools to do what you can do after. All right, so that is what I wanted to share with you today, and then I'm going to open it up to questions. And I'm going to stop sharing.
Thank you so much, Dr. Dagostine. I've known you for many years. And I learn something new every time I talk to you, and you just seem to capture exactly what I'm feeling or thinking, but I didn't have the words to express it. So you've done a fantastic job, and the comments that are popping up are saying the same thing. I want to invite everybody. We have about 15 minutes for questions, so please feel free to put them in the chat box, and I'll try to get to them. Got a couple to start off with. First, you were talking about that cheek swab. Why isn't that a standard practice? That sounds so simple and, like you said, could save us a lot of pain and time.
I think sometimes it's getting it covered by insurance. I mean, I'll
Mhm.
tell you, we don't run into too many problems with it. Medicare's been very, very good with it. Some commercial insurances are not. I know they won't run it until they've spoken with you. The company's called GeneSight. I have, again, no financial disclosures. It's just something that I have personally found very helpful with our patients because, you know, when we're starting meds and we're okay, this hasn't worked, and now we're bumping the dose and that doesn't work, and we're bumping the dose again. I mean, how much time are you spending uncomfortable while we're trying to figure it out? And it could be one of those red ones where your body's just never going to break it down, and I've just wasted 6 months of your life.
Yeah. All right. Question just came in that I had to combine some others. As the care partner, dealing with these symptoms is very tough and trying to identify how to work with it and what it is. But at what point do you overrule them? For example, we need to travel. You need to suck it up and we have to get on this plane. So, kind of when there's something that just needs to be done, how do you work with that person?
So it's tricky. So if it's apathy, it's a little bit easier because you're going to just plan it, and you're going to plan it so that it's very manageable. So let's say that you're someone who used to go to Europe for 2 weeks. That's probably not where you're going to start. Maybe you go away for the weekend, someplace close, where bathrooms are around. Like, you have to really kind of figure out what's the driving impetus of why they don't want to go. Apathy, like I said, a little easier. With the anxiety and the depression, anxiety, you need to build into it stuff that's so doable that people will be confident, right? So, okay, I've done a day, but I've done it in a smart way. I know how much walking is involved. I know water's available. I know where the bathrooms are, stuff that's really important, right? I know when I'm going to get to eat. I know that there's not going to be people, sort of behind me pushing me to move faster than I can or want to. And you build these little wins, and then what you do is with the little wins, you make them, you increase them each time, right? And when you deal with depression, depression's harder um, because with the chemicals involved with the depression, what I really think is helpful for people is find something they're passionate about, right? What do you love to do? Okay, pick a goal. And I will tell you, most people leave my office with what's our goal? Like, what are we working towards? What are you doing for fun? When's your next trip? What's your next adventure? If you're someone who loves the symphony, let's figure it out. I find that when people really don't want to do stuff, you have to kind of dig in and figure out why. And again, not for the apathy because that's motivational, but with anxiety and depression, what about it is upsetting? Like you're obviously having a thought that something's going to go wrong, right? Sometimes it's the bathroom, you know what I mean? And once you can sort of figure that out and strategize and figure a way to do it, sometimes you have to reinvent it. But taking into account the reasons why people, don't want to, like, what's the barrier? What's your barrier from going? And a lot of times that's helpful.
Mhm. Why do our symptoms cause us embarrassment and then increasing that anxiety? Why does that happen?
I think, with anything physical, nobody wants to look different, right? And so if you're shaking or if you're slow or you're a little stooped, you the science behind it is actually it's well documented from an evolutionary standpoint. We used to live in a way where if you were not part of a tribe, you would be shunned and you would die, right? You had to be part of a hunter-gatherer tribe, and if you weren't accepted, you would not survive. Now we don't live in that kind of a society anymore. We've got, DoorDash and, Amazon, whatever you use. But from our primitive brain, anything that signals you out and makes you look different or seem impaired in any way is going to trigger a fight or flight response because your body, from an evolutionary standpoint, never wants to be different. You just kind of want to be part of the tribe. Does that answer the
It's,
question?
I think so. I hope.
Yeah.
I think it did. Do depression, anxiety, and apathy, are they predictive in your PD progression and potential for Parkinson's dementia?
I think it's hard to separate which comes first. We know
Mhm.
apathy is more, we see it more with people who have memory problems. But I think what ends up happening, and so if you look at depression in and of itself, we will not diagnose someone with dementia if they have untreated depression or anxiety because your brain can't function properly when it's under that level of stress, when those chemicals aren't right. And so, you know, you can look very cognitively impaired when you're depressed, but you're not actually demented. When you're looking at outcomes, I think apathy is the trickiest because your brain's really just not offering to you that you should be doing the things that you kind of know you need to do. And so when you have someone who's really apathetic, it's really hard because you want people to exercise and you want them to to take pills so they can walk or drink their water, and they'll sit there and go, I'm not interested in doing it, kind of all right, maybe I'll think about it. And there's only so much pushing you can do because at the end of the day, Parkinson steals a lot from people, as you know, but autonomy is the last thing I try to take from people, right? I think it's important that when you can't control the way your body functions in certain ways, you should at least be in charge of, what you're doing, as long as you're not going to hurt yourself. So these are all really tricky things. That's where the therapy comes in. Our
Mhm.
social worker's fantastic, working with couples about this. So that's where, when I say to people, if it's not a good fit the first time, please keep trying because you can work together with a social worker or a therapist and go through these things and really talk about stuff and try and come up with some strategies and techniques that are, for you, not just sort of generic stuff.
Do you ever see the level of apathy change? So, if somebody gets to this apathetic level and you start implementing these techniques of maintaining a schedule, do you see that symptom improve, or do you just see a toolbox that's helping them to manage this for the rest of their life?
I don't tend to see apathy get tremendously better, but I see people
Hmm.
live with it, right? Like you've got diabetes and you've got to use insulin, right? You're managing it. You're not fixing it, but you're managing it, right?
Hmm.
And you can manage it. You really can. The trick is really getting people to understand that it's not a choice, and that it's not like if you just would work harder, or if they just cared more about me, they would get up and take their pills or do their exercise. And I think it's just so hard for people. And when
Hmm.
they can kind of understand that and you put in the proper techniques, the quality of life really improves. Even if people still,
Yeah.
their brains don't offer it to them, it just, they do better.
Yeah. So then that's another question is how do we get people to understand? How do we talk with our loved ones, our family, our employers, understand that this isn't just laziness?
For us, we do a ton of education in our office. We do
Hmm.
symposiums, we, do talks like today. We do, a lot. I do a lot of education in my visits because I get to have longer visits with people than, a lot of other providers get to have. But a lot of it is just really trying to be very open and asking questions so we get to the bottom of it. Because most care partners are not going to sit in your office and say, I'm really irritated that when I come home from work, he's just sitting there all day not doing what, he should be doing, because that might be a really embarrassing thing to say. So if you don't have a good relationship with your provider, it may never come out and then we can't help you. So it's just
Hmm.
it's educating the community. That's another big area where the support groups are helpful when you do the care partner breakout sessions. So someone can say, oh my God, my so and so is doing the same thing. Oh my gosh. Well, but did you know that that was apathy? Oh, I've never heard of apathy. Well, let me ask my doctor about it. So I think that that's another area where those online resources and in-person support groups, even if the person with Parkinson's doesn't want to go, right? Um, and I think Tom said that about Barcelona, right? It was really good to be with other people,
Yeah.
so that you can see, oh, wow, okay, this is pretty
Hmm.
normal, or, it's helpful.
Exactly. Blood work. You talked about blood work, for example, looking at, your vitamin B levels. For a person coming into this trying to assess their depression, apathy, and anxiety, what would be a baseline set of blood tests that maybe we should look at?
We always look at the stuff that your GP should be looking at anyway, right? So you're going to be tired and depressed if you're anemic. So we check a blood count. Always check we call it a complete metabolic panel where you're looking at the kidney function and things like that. We're looking at thyroid. We have a panel that we use with the B levels, folate, vitamin D. We'll look at different inflammatory markers, that kind of thing, where you're looking just to make sure you're not missing something really simple. It's interesting because, like I said, the number of times someone has a low normal vitamin B12 level, and I say, we really need to kind of supplement this, and I'll get pushback, pushback, pushback. But in our world as neurologists, low normal B12, it's not okay. It's really not. And you can see huge differences. Now, on the flip side, a lot of people will come in and say, I read an article and I need more B vitamins. And what I have to say about that is that if you're not sufficient, you don't need them. Now, you're probably not going to get toxic on them because they're water soluble and you will create expensive urine, but you're probably not going to hurt yourself. But there are some cases where people have gone pretty overboard, and you can actually get some toxicity if you're really, really overdoing it. So I would say, um, nutritional panels are very helpful. But before you really kind of supplement with those vitamins, it's important to check them and make sure you actually need them.
All right. Well, I think we're coming to the end. One more question. What happens? This was a question about the storage of carbidopa, levodopa, and drugs may be held for a few hours with more than 100 degrees Fahrenheit. I guess, is there
I think that's more of a
storage?
manufacturing issue.
Yeah,
Yeah, I don't have any data on over 100 degrees. I can't answer that.
yeah. All right. Well, I just want to say thank you so much. Comments are just coming in are just saying that this is some really great information you've given them. I want to tell everybody that we will have the video and the slides as well as the toolbox she just briefly showed us posted later on this evening tomorrow. We'll send out a notification. Um, Dr. Dagostine, Thank you again for joining us. It's just always a pleasure. You're just so full of information and useful walkaway tips, and I appreciate you so much. Everybody else out there, I hope you all have a wonderful day, that you got something good to come out of this, and that you have some good information to go forth, to talk to your families, to talk to your physicians, do that meditation, make those routines and those schedules. Hope everybody has a great day. Thank you.